All right, great. I think we'll get started. Dr. Kevin Bergman, co-founder of Global Ultrasound Institute, and here with Dr. Mena Ramos. We're really thrilled to host this webinar today, POCUS Curriculum Playbook for your family medicine residency. I've been really excited about this. And if this is your first GUSI webinar, so welcome. We're a community of physician educators, over a decade of experience in POCUS education worldwide. And our primary mission is to transform healthcare by safely integrating POCUS into day-to-day medical practice through education and training. And so today we've trained like thousands of healthcare providers through in-person courses and longitudinal mentorship and providing QA on our web-based platform. So creating a POCUS curriculum in a family medicine residency can be a daunting task. And today our panelists have all done so, and they're going to be sharing their experiences and pearls and pitfalls and wisdom in the hopes that it will help you be more successful in building your curriculum. So first, just a bit of intro. I want to start out with our panelist, Dr. Laura Adam. And by the way, everyone's a POCUS champion and family medicine residency faculty here. Dr. Laura Adam, faculty and director of point-of-care ultrasound at Boston Medical Center, and working in the family medicine residency there. Dr. Nicole Capizano is the director of clinical ultrasound program at Michigan Medicine in Ann Arbor. And Dr. Nicole Yedlinski, core faculty in family medicine residency at the Kansas University Medical Center in Kansas City. Dr. Brandon Chase, faculty and POCUS champion at Cascades East, OHSU family medicine residency program in Klamath Falls, Oregon. And Dr. Jared Doobie, residency faculty and POCUS champion, Department of Family Medicine at University of Wisconsin-Madison. So a really, really great all-star panelist group. We're really excited. I think joining us possibly a little later will be one of our moderators, Dr. Paul Borneman, who's program director of the family medicine residency and director of primary care ultrasound at University of South Carolina, and the founding chair of the AFP POCUS MIG and author of Ultrasound Primary Care, among other things. So hopefully he'll be joining us. But we thought we'd just kind of jump right in and start with just a kind of a high level thumbnail summary. If y'all be willing, maybe Laura, you could start just like 1 to 2 minutes of like, what does your POCUS program look like in your residency?
Yep, absolutely. Thanks so much, Kevin. Hello, everyone. Nice to meet you virtually. As Kevin mentioned, I work at Boston Medical Center in Boston, Massachusetts. We're a nearly 600-bed academic institution in the Safety Net Hospital in our city. We're affiliated with Boston University Medical School. We have about 100 faculty in our Department of Family Medicine. We've got a 12-12-12 family medicine residency and also a dual FM psych program as well. We have 14 community hospitals that are affiliated with our with BMC, and 6 of those sites are resident precepting sites. So as Kevin mentioned, I am the POCUS director for the Department of Family Medicine. I have 0.1 FTE for this role, which is equates to about 5 hours per week in my job. Currently, for our POCUS curriculum with the Family Med residency, we're doing twice weekly inpatient ultrasound rounds during morning didactic time. We also have every other month sim lab sessions for the family medicine residents to practice some hands-on scanning. Our department has a subscription currently with GUSI. We have so for the last 2 years. And so all of our residents have access to GUSI and that platform, as well as 10 additional kind of interested faculty. We do monthly hands-on learning opportunities also for our faculty. We have a wonderful ER provider who collaborates with us and helps to teach hands-on skills as well in the Sim Center. With that? Yeah, and so, yep, we've done a variety of lectures and hands-on practice, and then coming up, we have a collaborative session with our nurse midwives and family med practitioners who work on the labor and delivery floor to get everyone proficient in limited OB ultrasound. So big picture, we're a big department. We have a large family medicine residency and very few faculty that are credentialed in POCUS apart from some of our sports med colleagues. So nice to meet you.
Wonderful. Dr. Capizano, how about you? I think muted, Nicole.
Sorry, I was mute. I was saying that it's a pleasure to meet you guys. Yes, I work at Michigan Medicine. This is also a big hospital. We have two different type of hospitals. We have an academic setting, and we also have a community type of hospital. We have a residency program where we have 13 residents per year. So this program and everything started in 2019 when I was nominated as a POCUS champion in this area. So at that time, because we didn't have I didn't have any training in POCUS, but I was really interested on creating a formal curriculum for my family medicine residency. So what I did is I reached out to the emergency department because they have a strong reputation in POCUS, and they also have a POCUS fellowship program. At that time, I was also awarded as a scholarship. And as part of the scholarship, I asked my department to invest in my training and education to become a POCUS expert. So then I started a POCUS fellowship at the emergency department in July 2020, which it was in the middle of the pandemic. It was really hard, but it was actually interesting for me because there were no other fellows at that time. So I was the only fellow. So all the emergency department physicians were focusing on my training. So during that time, I gained a strong training, not only on ultrasound education, but also in academic and administrative experience. So currently, our family medicine department, we have 2 ultrasound machines. That was also part of the scholarship that I applied. So we have 2 family medicine resident clinics. So 1 ultrasound machine is for each clinic. We have a formal POCUS curriculum for family medicine residents. They are able to go to the simulation center. They also are able to scan on inpatient and outpatient scanning. Because of all this program and the success of how this program was doing, we have also developed an ultrasound track curriculum for a 3rd-year family medicine residents, because those are residents that they really want to have intense training. Currently, we also have a curriculum for faculty training. We have 4 faculty who are doing a special training for ultrasound, and I was able to get some protective time for them. We also have our own cloud to save our images. It's called QPAD. Probably most of you guys are familiar with that. We do a strict Q8, which is quality assurance. And so I'm able to give feedback to residents and faculty who are in training. Credentialing is in place. We build most of our ultrasounds. And finally, I was able to create an advanced primary care ultrasound fellowship. Our first fellow is graduating this month, and our second fellow is going to start July 1st. That's what I have.
Wonderful. Thank you so much. It's very impressive. Great to hear all that. Dr. Yedlinski, Kansas City.
Hello, I'm Dr. Nicole Yedlinski. As Kevin said, I am core faculty for the family medicine residency at the University of Kansas in Kansas City. And then I'm also the program director for the sports medicine fellowship. So I'm the primary educator for the fellowship in musculoskeletal and sports ultrasound. I am RMSK certified in that role, which did help with credentialing at a large academic medical center. When I came to KU just under 6 years ago, one of the first things I needed to do was purchase a machine for our family medicine clinic. As many people can imagine, the machine that they had was a dinosaur from the 1980s. So the first thing I needed to do was to upgrade our machinery and equipment. I was able to purchase a cart-based machine, as well as applied for a grant that got us 4 handheld devices. We are an 1199 program. We have 2 residents that go out for their 2nd and 3rd year to do a rural residency that's about 2 hours away from Kansas City. I did also partner with our emergency medicine colleagues. They already had a 2-day Intro to POCUS course for the interns. And I met with their POCUS champion from the emergency medicine residency. And in exchange for my time teaching musculoskeletal ultrasound to the emergency medicine residents, we now have all of our interns go through with the emergency medicine residents, as well as some general surgery and OB residents, a 2-day POCUS course. I also, right now, I'm still the only POCUS champion at our program, though we have another faculty who is going through the Gussie training. So hopefully we'll have some company soon. We do, in addition to the 2 days Intro to POCUS, we do ongoing monthly. Wednesday afternoon is our core protected time for the residency. So we do hands-on training one afternoon each month. And then we also have what we call resident development time, usually around December, where we also go through some additional POCUS scanning and POCUS applications. We have done some Gussie training with additional faculty. So there are some faculty who have some POCUS skills, and then many, I still do OB as well. And so many of our OB faculty are trained to do some OB scanning, including dating and BPPs and all of that type of stuff. I think that's it.
That's wonderful. Thank you so much, Nicole. That's great. Brandon, how about you from Oregon?
Sure. Nice to see you all. My name is Brandon Chase. I'm a core faculty member at Cascades East Family Medicine. We are a rural training program in Southern Oregon, at least 200 miles from the nearest program. And the only residency here is our 888 Family Medicine residency. And we've been working on our POCUS program probably since 2015. What it looks like today is when the interns arrive, I have about 2 half days of training with them during the 2 weeks of intern orientation. And then during the 3 years that they're here, we do monthly protected time workshops, which are primarily hands-on. Like Laura Adam, we have subscribed to the Gussie online offering, so that offloaded a lot of the work of creating didactics for residents. So we use a flipped classroom model where they have access to the Gussie modules for 3 years. And before the workshops, we ask them to review the relevant scan topics. And then we kind of do a little high level overview and then mostly practice scanning. We do some bedside pathology rounds, scanning on the inpatient service occasionally. I've recently got the residents to start saving their scans instead of just what we call phantom scanning, and I'm requiring them to present at least a couple cases during their 3 years here at our noon conference. And those are pretty much image review, quality review, and then discussing clinical applications. We have an ultrasound elective that's a couple of weeks that is really self-directed that the residents can participate in, and a lot of them do. And then they can focus in on whatever skills they're wanting to build, whether it's musculoskeletal, ED, inpatient, or OB. Being a small community program, we don't have the luxury of having an ED POCUS program or a critical care POCUS program. So we're kind of having to rely on the resources we have available to us and just try to improve the program a little bit every year. We do have some faculty involvement, but I am the only POCUS champion. But each year that some of the faculty get more comfortable with ultrasound and are using it more. So
wonderful. Wonderful. That's great. I've watched your program develop over the years. So kudos to everything you've done there. Jared, how about you? Can you share some of your high level, what your POCUS program looks like now in Wisconsin?
Yeah, certainly. Thanks, Kevin. And so awesome to hear what everyone's doing. I'm like, I have so many questions for all the other panelists, and I feel like I have this feeling, and I'm sure you all have too, of like, you're sort of in a silo on your own. You're the only champion. And so it's really cool to get together with a group like this and and just hear what everyone else is up to. Yeah, so I'm Jared Doobie. Nice to meet everybody. I'm out at the University of Wisconsin in Madison, and our POCUS program started pretty much when I started as faculty in 2019. And currently what it looks like is that I have a 10% FTE for protected time as POCUS director. I'm currently the only credentialed non-OB POCUS faculty in my department, but I'm working on training a couple of my other faculty up. We do ultrasound rounds on the inpatient teaching services. So we have residents working at both the university hospital and also one of the community hospitals in town. We're a pretty big program. We have 16 residents per class, so 48 total residents. And then I do one afternoon workshop with the interns every year, and then 2 workshops with the senior residents each year, which is like a full afternoon in like our university simulation center with standardized patients. In the process currently of building like a pathway for residents who want more than just like the basic exposure to like with the goal of when they graduate, they would have the experience and the competency to like apply for credentialing at an institution. So that's sort of like in process to build that. We have a handheld ultrasound setup at each of our 4 residency clinics and also at both of our inpatient teaching hospitals that are integrated with like a middleware software program that can be sent to PACS for billing if desired. But otherwise it's just like a nice place for scan review and education. And we have a resident-led POCUS interest group actually that is meeting like every other month in the evenings, and I try to get there when I can. And they just like scan each other, which is pretty cool to see. We also have a Gussie subscription, so all the residents have access to that, and interested faculty have access to that as well. So yeah, that's kind of where we're at right now with our program. I'd say the biggest like limiting factor right now is just like wanting to get more faculty in my department credentialed so that I can have other people be, doing the bedside pathology rounds on the inpatient service when I'm not available and helping to table train at workshops. Fortunately, at UW there is an ER ultrasound fellowship, and all the ultrasound faculty in the emergency medicine department are very just like pro POCUS for everybody. And so they've been really generous with their time to help teach some workshops with me, and were a great resource for me when I was getting trained myself. And yeah.
Wonderful. That's really great. And as you can tell that we've got like, there's no one way to do this. And there's so many different ways, and some have started outpatient, some have started more inpatient. There's just quite a bit of heterogeneity. And I thought that we'd like to hear about maybe what was the first move, like kind of how did you begin it? Most people need to get themselves trained as a POCUS champion, get yourself to a place where you're starting to feel comfortable. And I guess once you have that, and then there's some kind of hardware, that there's cart-based machines or there's handheld machines or a machine. I was just wondering, maybe Laura, if you could start out, like after those 2 things are in place, how did you begin?
Yeah, so we were fortunate at BMC. There was a hospital-wide POCUS task force that was generated in 2018, and it had representatives from our internal medicine department, ER, palm critical care, surgery, trauma surgery service, anesthesia, family medicine, obviously. So we actually started a collaboration hospital-wide, and basically generated a credentialing pathway for each department, very similarly worded, but basically collaborated on a document that got approved for each department through our central credentialing at Boston Medical Center. And that was kind of the start of our POCUS program in the Department of Family Medicine. And then specifically in family medicine, in our department, I sent out a survey for a needs assessment and just kind of general interest, both to family medicine residents and our faculty, just to get a sense and a feedback of where they feel the role of POCUS is moving forward, how interested they are, what their background has been. And that was a pretty strong, overwhelmingly positive response in terms of desire and eagerness for getting POCUS going in family medicine. So it's a pretty good launch pad for our new chair that had joined in our department.
Wonderful. That's excellent. Brandon, how about you? What was one of your first moves?
You stole my first two moves. So the first move was writing a grant and getting two machines, one for clinic, one for the hospital. The second move, which kind of is ongoing, but was learning the skill. And that took a long time for us. I'm not fellowship trained, and so we, kind of the way you learn anything, you take an interest in it. You start networking. We went to CME events. I teach the trainer training, which I think is where I met you, Dr. Bergman, maybe in 2017. We have a technical college next door to us that has a radiology imaging program. And so they have sonography instructors. And for a couple of years, we would go over there with the residents and get training from the folks who teach echo techs and ultrasound techs. That was really valuable. But we did realize at some point that they're not making clinical decisions. So although they're technical experts, they couldn't get us that final distance of like when we should be doing scans, what information we needed to obtain, and how to make those clinical decisions. So we kind of came back internally, and the most important thing for us really was having a few interested people starting to scan in clinic, kind of gaining comfort and competence, figuring out when we could make clinical decisions, and then slowly kind of incrementally improving our comfort and our skill set. And then just recurrently doing the didactics and presenting cases and presenting scans to residents and faculty. I'm pretty lucky being in a small hospital. I went to our hospital administration and asked about credentialing, and the general surgeon who was chairing that board was like, yeah, ultrasound is great. You guys should be doing it. So we have a lot less bureaucracy than some larger institutions do. So we haven't put a lot of effort, and we've been kind of self-monitoring and haven't put a lot of effort into credentialing, but I realized that is something we will need to do someday. And then also putting effort into training other faculty, I think, is really important. The first few years, training residents, they have 3 years, they're interested, they're like sponges. They come out of medical school now with more and more ultrasound experience. And we were getting some pretty competent third-year residents, and then they disappear and you lose your best instructors. And so then I realized that really what we need to be doing is training some faculty who are going to stay around. And people have mentioned that your best faculty might be residents who you have trained or gone through your POCUS program, your fellowship, and then you retain them as faculty afterwards. And so that might be one option for building some depth in your POCUS department among your faculty.
Excellent recommendations there. Nicole Yedlinski, how about you? What were some of your first moves?
Yeah, so similar to Laura, we had, when I got to KU, there was a multidisciplinary POCUS group in the hospital that was sort of a best practices amongst different departments: emergency medicine, critical care, pulmonology, radiology. And I sat at that table as family medicine. And I think that was really beneficial to have somebody from family medicine there. There was initially some pushback from folks like infection control, who were trying to say we had to do high-level disinfection of every probe after every scan, and that was quickly squashed, which was really nice. I came into KU already having at least really good, musculoskeletal sports ultrasound skills and fairly decent other applications. I did do the 2-day course out at Contra Costa. That was the precursor to Gussie, just to build on those skills. And then partnered with our residency program director to sort of see how that was going to look. Like I said, we needed to get some machines in the clinic for residents and faculty alike to use. And then more recently, we're on our 3rd year of developing POCUS at the medical school level. So we now have an M1 and M2 curriculum introducing POCUS applications throughout that as longitudinal. And now we're trying to move on to how do we then incorporate POCUS for the 3rd and 4th year medical students on a more reliable basis. So similar to what Brandon was saying, how do you get that motivation? How do you get POCUS integrated at all levels? Now with the residency, we have the POCUS course, the 2-day course at the beginning of 1st year, and then integrated for 2nd year and 3rd year. They have the opportunity to do an elective, which many of them do. One of the difficulties in our program is we still don't have a strong POCUS presence on the inpatient side, at least on the family medicine inpatient team. So that's one of my next goals as I'm training up the other POCUS champion in our residency. She hopefully will take over because I don't do inpatient medicine. So hopefully she'll be taking the initiative for that. And we're still working. It has been a almost 5-year process getting that middleware software. For some reason, it has been incredibly difficult with all the complicating factors. Interestingly enough, our department supports it and is willing to pay for it. It's all licensing and the IT support that's been difficult.
Well, thanks for sharing all that. That makes a lot of sense. And Paul, it's good to see you. I thought maybe hi there, Paul. Would you also be willing just to share just like maybe a minute or so of some of your maybe what your first move or two when you were starting your program?
Yeah, it was where I am now, University of South Carolina, fairly easy because I came in basically hired for the role of starting an ultrasound curriculum. So this was a great position to be in because they were looking for somebody to come start a curriculum. The medical school was already willing to support some of my time and provide us with some equipment because the medical school at University of South Carolina has had an ultrasound curriculum for their med students since 2006. So this was like around 2014 when I came here, and they were looking to expand it to the primary care residencies. So they even had a block already blocked out for our residents to do ultrasound. They really weren't doing anything yet. They had the time. They were basically just wandering around the ER and trying to learn how to ultrasound on their own. So had the work cut out for me, but had the support in place, which is really important. And I guess that's one thing that I would remind everybody. I mean, if you're already in a program trying to start a curriculum, that's one thing. If you're a resident who's planning to graduate and go somewhere as faculty to start a curriculum, which I say that because a lot of our residents do, they come through, with our curriculum, and then they're kind of in high demand for having had that experience already. I would just remind you that when you're making those initial negotiations with potential future employers, you have way more bargaining power than they do initially. Once you sign the contract, it's completely in the opposite direction. So ask for all those things. If they really want you, they'll try to make it happen. If they can't, worst cases, they'll say, sorry, we can't make it happen, but it doesn't hurt to ask. So ask for things like protected time, ask for, equipment, the equipment that you want, ask for guarantees that they'll, procure those things for you. You can really actually negotiate a lot. But again, once you sign that contract and show up and you're working there, you really don't have that bargaining power anymore most of the time. So those are important things to think about. And I guess I posted, we published our curriculum back in 2017. If anybody wants to look at that, some outcomes we had from initially, I put it in the chat. But so I won't go into detail about everything, but I'd say that where you start, really, it can be almost anywhere. If you look at the new RRC requirements for family medicine to have point of care ultrasound, they're very vague, right? It just says I think, an experience or must have experience in point of care ultrasound. That could be anything. So consider starting with what you have. There were questions about how do you get money for equipment and QPath and everything. And I'd say you don't necessarily need to have everything in order to meet this requirement or even to get started. And generally, if you start with something, if there isn't already enthusiasm and interest behind point of care ultrasound, just starting with something small will usually start to generate a lot of buzz and a lot of interest. So just find a way to get started. If it's starting, maybe just getting the Gussie modules for your residents, or maybe you don't have an ultrasound yet, or if you do have a few $1,000s, maybe you start with one pocket ultrasound or something like that, and then you can expand from there as interest builds. You may not be able to get grant money, but most residency programs could afford a couple $1,000s for an ultrasound to start a curriculum, which is now an ACGME requirement. So find something small you can start with and start wherever. Maybe a lot of programs start with having an elective, or just with smaller than that, just having didactics dedicated to point of care ultrasound. That's a great place to start too. So just sometimes just starting is just building interest and generating some of that buzz in your group, and then you get more buy-in, and then it's a lot easier to build up from there.
I think that's great advice. Thanks so much for sharing all that, Paul, and all of your experience. Along those lines, wondering for the panelists, what would you maybe do differently, knowing what you know now after your lived experience and creating this and kind of trial and error and the iterative process that this all is? Do you have any advice for the participants about what maybe they should potentially consider doing? How about you, Nicole Capizano? Could you maybe share a couple of your experiences of that?
Well, I don't know if I will do something different, because I think I felt fortunate that everything that I asked, I got it. So I think when I came to this job, they really needed somebody to start the project. I came to Michigan Medicine basically at the end of 2018, and in 2019 they were looking for a POCUS champion. So when I presented all the ideas that I really wanted to do, they basically said yes, because they thought that it was going to be a robust program. I think asking for help or reaching out to some other departments, like I did with the emergency department here in Michigan, was grateful, because I can know, they helped me a lot with all the process. Maybe one thing that I could do different would be probably a little more of negotiation, trying to get more protective time for the faculties who are getting trained. Because one of the things that I am getting right now is a little bit frustrating that there are faculties who really want to get credentialing in POCUS, or at least get some skills, and it's hard for them because they don't have the protective time. So that's the part that I probably didn't negotiate very well at the beginning, but I'm working on that.
Anyone else from the panel want to share?
Yeah, like I shared before, one of our struggles has been getting that middleware software initiated. And I think I would have, had I known then what I know now, I would have developed a better way to track scans and do QA/QI in place while all of that process was taking place. And also, I think having a more concerted effort at training other faculty earlier on would have been beneficial. I think we would have been further along by now.
I'll just make 2 quick points. So I think I would focus on not credentialing more than 1 or 2 faculty kind of all the way through, focus on inputting, investing in a couple faculty instead of trying to broaden the net and get 10 or 12 people kind of interested in credential at the same time. and thinking about faculty being think about interested faculty in sort of a tiered approach. So there's going to be a few that are going to be fully credentialed and functioning in POCUS in their clinical work. And then there's going to be another subset of faculty who are going to be generally interested and supportive and maybe, maybe not fully credentialed, but definitely interested in learning more and getting their hands wet. And then there's going to be always a subset of faculty that are really not interested in POCUS, or maybe interested in POCUS from a periphery. So I would really kind of think about not trying to get everyone up to speed all at once. And then I also have just really reconsidered, like, what's the highest yield use of my time? And so I think, for inpatient rounds specifically, we have 2 medicine teams. So that gives me an opportunity to capture 4 to 6 residents plus a couple medical students, and then 2 attendings in a 30-minute session where we can all join at the bedside and do some learning and teaching. And so I think that's been a really productive way to spend my time in terms of teaching, as opposed to just having an open sign up and hope that 1 or 2 or 3 people kind of trickle in for the hour or 2 that I'm available.
Yeah, I have a couple of thoughts to share. I mean, one thing that just strikes me listening to everybody, it's like every department and institution there's like idiosyncrasies at every place, right? Something I'm hearing like, oh, it's so hard to get cute. I'm like, that was easy for me. But then something else that was that's been really difficult for me was easy for someone else. So it's going to be so variable from place to place. I think like the themes I think of that emerged that have been helpful for me and that I wish I had doubled down on more. One is just to be really organized in terms of like laying out a vision for like different like phases of how this is going to go. And that was useful for me. And when I was just garnering support from my department. So like, even just like as simple as just like having a PDF with like a timeline, that looks nice, that you can be like, here's the phase 1, here's phase 2, here's phase 3, because then when your department chair is like deciding whether to give you FTE, they understand in a practical sense, like what they're investing in. The other thing that I found really helpful that I'd recommend is like in your own training is identify a mentor, someone who you can go to with questions. And because that helped me along the way. And when I was like, not sure what direction to head to next, I would ask or talk with one of my mentors about it. And yeah, if you can, get some protected time, like people are saying. And then one thing that I wish I'd done earlier that eventually was really helpful for me was getting like an administrative, like a project manager through like the administrative kind of wing of my department. Because when it came to purchasing the handheld devices, we had the money. And it was like 16 months later that we were able to place the order because of all of the bureaucratic, like red tape of like the different like arms of the organization and who's going to own the machine and who's going to make. I mean, I just can't even begin. And having a project manager who seemed to enjoy all of that and really helped me a lot was just made it so much easier. So if you have that as a resource in your department, try to find someone like that. And then the last tip that I'll just throw out there is like, especially if POCUS doesn't really exist much at your institution or within your department, and you're worried that, I don't know, the cardiologists or the radiologists are going to be like, oh, family medicine doctors shouldn't be doing POCUS. Get out ahead of that. Like I had a meeting, I went on the advice of one of my mentors who shall not be named, Dr. Bergman. He, I was like, where should I go next? He's like, just get really good with echo, right? So I was like, okay. So I reached out to the cardiology lab, the echo lab. And I sort of cold emailed the medical director of the echocardiology lab and was able to get my foot in the door just for a meeting. I was like, look, I just want to talk to you about this. Like, you've probably heard about POCUS, and I just want to make sure we're doing the right thing. And when I went to meet with him, the way I presented it was like, I'm really concerned about safety. And I'm concerned that I don't want residents going and just scanning people and saying someone has this or doesn't have that diagnosis. And I want to make sure we're really above the board and that everything's really, and so getting ahead of that and like sort of being the one to be the first person in the room to like express that concern really just like took all the wind out of his sails, because he was like, great, like I totally agree with that. And then from that point, even at the beginning of the meeting, I think he was not going to let me spend time in the echo lab, but after that, he was happy to have me go and like shadow the sonographers, which turned into like after a couple scans, if you asked them good questions, they'd be like, why don't you do the first scans? And so I was like able to scan with sonographers in the echo lab and then go talk with the cardiologist about the scans afterwards. And that was big for my learning and just building my confidence. So yeah.
Thanks for sharing all that awesome advice. Thank you. Brandon, how about you?
Just to kind of piggyback on your comments, Jared, is both how every program has idiosyncrasies. I like hearing your story about the echo and cardiac scanning, because you really need to figure out what resources you have that are specific to your institution and leverage them in the best way that you possibly can. And then also reach, as you say, to mentors outside of your institution. And there are a lot of sources for that. The AAFP has a member interest group where you can chat and discuss, and they have a library with a ton of documents that people have posted over the years and resources, curriculum development. I think STFM is in the process of developing a training program for faculty members. I don't think it exists yet, but that will be coming in the next year or two. So leveraging your resources at your institution, working as best you can with what you have, and then reaching outside your institution. In terms of things I wish I'd done better, I think they've already been said. I think paying a lot of, the sooner that you can get people recording their scans, the better. If you get residents who are just used to grabbing the machine and scanning and not saving, it's going to be really hard to train them to create a file folder and save images. And so the earlier you can get that done, whether the hurdle is your IT department or funding for some external source of imaging, I think that's really important. And the other one that has also already been mentioned is faculty training. I said that I worked really hard on training residents, and then I just think of like, if only one faculty member used a stethoscope, it would be really weird at a program. Not that you're going to get everybody to be a POCUS champion, but you can't be everywhere all at once. And so you really need other faculty members who can supervise and answer questions at the point of care when someone's scanning something in clinic or on rounds. The more faculty you have trained up, the more robust your program is going to be. And one of the barriers to training faculty, honestly, is not so much interest as time. I have a lot of faculty who are interested, but they're busy and they're being pulled in a lot of directions. And so if you can convince your department to buy out some of their clinical time, even temporarily, so they could do like a 6-month kind of mini intensive, but that will increase the uptake on faculty, is if you can find some way to get their protected time. And I think that will pay dividends down the road. If you get that initial investment, it will help a lot.
That's great advice. Along those lines, a question has come up in the chat about getting protected time for yourself as a POCUS champion and also for your other faculty members. I'm wondering, could you relay any like hints on how you got that? Was it easy or hard? Did you have to kind of frame up the entire POCUS program in order to get buy-in from the admin? If anyone wants to share.
Yeah, I'll weigh in. So for me, I am fortunate that because I am the program director of the fellowship, but I only have either 1 or 2 fellows a year. So that is not that difficult. And then I also have protected time for residency as core faculty. So I am 0.6 clinical, 0.4. And because I also do OB, right? So my OB call is also another opportunity for me to do some clinical stuff. So I think in that situation, I have some extra time, but like what others have said, the hard part isn't for me. The hard part has been for getting other faculty who need to get trained up.
Yeah.
And also I'd say, 3 years for family medicine is not that long of a time. And so anything that you can do for getting time for the residents to learn,
Yeah.
incorporating POCUS into other things, like we have a great simulation lab, so incorporating POCUS into those simulation scenarios or situations like that.
Yeah, I think it's important to create like a necessity. This is something that every department should have. And if they really want to, to make this POCUS successful in the department, they need to invest at least in one championship. And then right now, for example, the way that I am trying to get protective time for a couple of my faculties is because we're billing for the ultrasound. So we're trying to get that money to pay for at least 6 months of a scholarship for like I don't know, 0.10 for one faculty. So then they can be trained. As Laura said, they don't need to be completely, efficient in all the type of ultrasound, but at least for soft tissue, I don't know if they do inpatient for echo, IVC, lungs ultrasounds, the type of ultrasound that they are going to use more frequently. I think it's important to train faculties as well, because there is the bridge between residency and faculty is getting bigger. So residents are learning ultrasound more, and they are more, able to actually work directly with the ultrasound than faculties. And if the faculties are precepting, they need to have some basic type of ultrasound knowledge to precept those residents, because if not, they are basically calling us all the time, and we also need to take some time off. So I think negotiation is the key.
Laura, was there something that you were going to add on that?
Yeah, no, I agree with everything that's been said. And I think I mentioned earlier, I think, to really sort of like quantify, why this is important, I think a simple survey is kind of, is helpful to just, put some specifics on the amount of interest and the importance of the relevance of POCUS for the department. So I think that was helpful for my chair to see actual data on what percentage of faculty and residents are actually like serious about this topic.
That's a great point. Always definitely very convincing. Question also came up about which scans did you all start with? Because if you have all of family medicine, inpatient and outpatient, it's a bit overwhelming. And so the question for the panel is, both for your faculty and for your residents, where did you begin? And yeah, if anyone wants to take that.
I'll just speak to what I'm doing for my residents, and I can talk a little about my own experience. But for residents, for my interns, I focus on more inpatient stuff because they spend so much time in the hospital. And so what I do with them, we definitely do like flip classroom models. So I have required like videos and stuff, some of which are the BC modules, and some of which are just other free online resources for them to do ahead of time. So we can do mostly practice scanning and looking at pathology. But I use the CLUE protocol, which is the cardiac limited ultrasound protocol that is great for just like volume assessment in the hospital, but includes some heart scanning, lung scanning, aorta. And then for my senior residents, I focus more on more outpatient clinical stuff. So everyone's really wants to learn musculoskeletal ultrasound, and that is super applicable in the clinic, but I would say it's probably like one of the hardest applications of ultrasound. So we've been doing like AAA screening as kind of the focus for like a baseline for clinic stuff. And for myself, I really tried to kind of invest more heavily in like echo, so cardiac ultrasound and musculoskeletal ultrasound, by like going to expert courses and spending time in the echo lab, because I feel like if you can do those, then it's a pretty good base to be able to do other indications as well.
That makes a lot of sense. Dr. Yedlinski, where did you begin with your residents in terms of the content?
Yeah, I think for me, it was a lot of basic MSK, especially, as well as skin and soft tissue. So basic, differentiating abscess from cellulitis. Is there a joint effusion or not? And then I felt like DVT scanning was also pretty straightforward to learn, and at least for my clinical practice, pretty applicable to the outpatient setting.
Can I chime in, Kevin?
Please.
Because this it's a good question. This is something that we thought a lot about when we were first starting with our curriculum, because there's really an infinite number of applications that you could approach, especially in family medicine, right? Because we're doing everything for everybody anyway. So we kind of looked at least at the time, what applications would be the highest yield. So which ones would be the most useful to most family physicians, and also had some evidence already in the literature, usually coming from ER, because at that time, that's pretty much where all of the evidence for point of care ultrasound was, and evidence that it could be learned with limited directed training. So like after doing 25 or 50 scans or something. And so we came up with a list of, I think it was about 7, but it was limited cardiac, limited lung. We include IVC in cardiac, aorta, DVT we included too, Nicole, because that is actually very high yield and a lot of evidence behind it. And then we included some like very limited OB and some limited musculoskeletal, because I agree with what Jared said. It's like that's almost like a whole nother world. If you get into musculoskeletal, there's so much to learn, but you can focus it into something like just looking if there's an effusion or not, or the Ottawa ultrasound ankle rules. There's a way to incorporate ultrasound into that, which even further decreases the need for x-rays. So focusing in on some of those protocols. So that's what we did. So we kind of came up with that list, and that was something that we expect all of our residents during the 3 years in our curriculum to be competent to perform by the time they graduate. And that's something we follow them for as a competency and assess as a requirement for graduation.
Dr. Adam, how about you?
Yeah, we started out mostly on the inpatient side, and kind of thought about it just in systems. I started teaching, we did kind of like, we start usually with a knobology basics of ultrasound with our intern orientation, and then pick systems that are from a technical scale point, I think simpler to do. That's sort of been our approach. So I've started with renal ultrasound, renal bladder, and then from there maybe gallbladder. Lung ultrasound I think is pretty quick to pick up. I think limited cardiac takes more advanced skills just in terms of the fine tuning. So that tends to be towards the end, like later in the year. But that said, I mean, like I mentioned with ultrasound rounds, I mean, we often end up incorporating multiple systems in one, even if we're scanning someone for volume overload, kind of while we're on the right upper quadrant, I'll just say like, hey, let's take a peek at their gallbladder too, so I think, we tend to, in practice, like incorporate quite a few at a time. But when we're doing the sim sessions, I've tended to do, like technically easier skill sets first.
Dr. Chase, how about you?
I really like the what I call the lung base view. So the curvilinear probe at the base of the lung, which is really close to the view for kidney, bladder, spleen, liver, free fluid. So I feel like that sort of lateral view is really high yield for multiple scans. It teaches a lot of basic hands-eye skills, teaches like organ identification and navigating. So that's one that I really focus on. And personally, I find for the lung scan itself, I find the lung basis to be the most useful part of the scan, looking for effusion or consolidation. And so I start with renal, bladder in our intern orientation, And then I also do a limited cardiac, heart, lung in our intern orientation, but I realize that's a big lift. It's a lot of information, but I just want to present it once to them. But again, really focusing on that lateral view, because I think after a few hours, they can go out and start doing that. And it's useful for a kidney stone. They can look for hydronephrosis. You can look at the character of the liver for cirrhosis. You can sometimes find the gallbladder through the liver. You can look for free fluid. And then post-void residual is a really common urinary obstruction in the hospital, in the clinic. So combining that with bladder view and just simple bladder measurements is one. And then the other module that we do during intern orientation is MSK focused, and agree with the previous comments that MSK is a huge beast on its own, and you can do a sports medicine fellowship and spend a year scanning. But I love MSK. It's been fun for me personally just to kind of keep expanding my skills. But you can also, I separate it into diagnostic and therapeutic. So I think I want residents to be able to guide a needle under ultrasound guidance. And so I focus on some basic skills like knee effusion and like lateral suprapatellar aspiration, if there is a big knee effusion. And you know, they're already using ultrasound guidance for central lines in the hospital. So just translating those skills to MSK applications. Once they get a little more comfortable, carpal tunnel injections, I think there's some literature saying those are better, more efficacious with ultrasound guidance. So yeah, if you're going to go into MSK, keep the topic simple, and then in your mind split the different between diagnostic and therapeutic. You know, doing a diagnostic shoulder ultrasound takes a lot of skill and a lot of time to learn. But finding a structure, finding the subacromial bursa with ultrasound and guiding a needle to it is not that difficult. It's a much easier skill.
And I would say too that learning the basics of ultrasound guided injections is pretty easy too, because you can practice on tofu. You can practice, you know, there's a bunch of different gelatin models that you can find articles about. And so that's another great skill, because I joke to my residents that I'll inject anything as long as I can get to it with ultrasound and a long enough needle, because the principles are there. It's also really good for, you know, IV access, vascular access.
Yeah, Nicole, that's a great point. I just want to dovetail that. We also have a bunch of phantom gels in our sim lab, and I think ultrasound guided peripheral IV placement is a really high yield skill for learners and faculty for the DIVA population that we have in our hospital.
Absolutely. Well, thank you all. We're just about the top of the hour right here, and I just want to give a lot of appreciation and thanks to all of our panelists. Thank you all so much for your time and just be willing to share your experiences and offer your pearls of wisdom. And yeah, just really appreciate it. It's been just a wonderful discussion. And if anyone here has further questions about like curriculum, we have a few things that I think are in the chat that Dr. Ramos has put in the chat and on our resources page, and we're continuing to try to just like put as many links out there and as many different kind of curricular examples out there as possible to hopefully make it just easier and have you all have a successful POCUS program that we all really hope for. And it's just so great to see this in family medicine and us really taking the lead. I'm just really proud of everybody here in this group. And thank you all for your time, and best of luck, and we'll see you on the next webinar. Have a great day, everybody.
Bye.
Bye.
Take care.
Bye-bye.